Good evening, one and all. We are here in yet another important topic which we are going to discuss in our webinar in ET Health World. So, agentic AI is a topic for the day. Agentic AI goes a step beyond traditional AI. It doesn't follow instruction. It can make decisions and act on its own. And in healthcare, that could mean faster diagnosis, smarter workflows, even new breakthroughs in treatment. But it also raises tough questions. Can we trust AI with patient lives? How safe is the data? And where do doctors fit in the future? Today, we will discuss further about this new thing which is happening in healthcare, whether agentic AI is healthcare's biggest opportunity or it is a bigger risk. So we have a heavyweight panel, all experts here as usual with our ET Health World. We have Dr. Sushil Kumar Meher, Head Health IT and CISO AIMS New Delhi. Thanks a lot, Dr. Meher, for joining us. We have Mr. Rajiv Sikka, Group CIO, Medanta Hospitals. Thanks a lot, Mr. Sikka, for joining and giving your time. And next, we have Dr. Rahul Bhargava, Principal Director and Head of Hematology, Hemato-Oncology and BMT, Fortis Memorial Research Institute, Gurugram. And with me, I have Mr. Vikas Dandekar, Editor, Health and Pharma, the Economic Times Group. Also joining with us, Dr. Sujoy Kar, Chief Medical Information Officer and the Vice President of Apollo Hospitals. Thanks a lot to all the speakers who have taken time, and it's a very interesting topic, and I'm so excited. So let me start with the first question. Agentic AI can act on its own, which is what we all know, at least people, common man like me know, and something we have never followed in healthcare before, which raises a lot of doubts actually. In a country like India, where one doctor serves 1,500 people, this sounds like a breakthrough. Yes, that could save millions of lives. It is a technology which would help. But with nearly 2 million cyber attacks on our healthcare system, correct me if I'm wrong, last year alone, I'm talking about, is this also a Pandora's box that could compromise patient safety? Let me go to Mr. Sikka first to know the technology part. Mr. Sikka, please.
Sure. So, ma'am, you touch upon a very important, and very relevant stuff. As a matter of fact, last 3 months we did a very successful pilot, and now it is in production, where my OPD scenario is being run by agentic voice AI. So what it means is that, assuming me and you both are there in a doctor chamber in the OPD, and I'm a patient and you are a doctor. So whatever conversation is happening between you and me, it is getting converted into a prescription directly. So it's not voice to text. It's a voice to prescription. It's not a dictation. It is filtering all the noises which are there in the ecosystem and, beautifully modifying it into a typical prescription. Now, you'll ask me, what is in it for the doctor? What is in it for the patient? So there are, if I say there are three broader level advantages. One, definitely for the doctors. See, you have to understand that in India context, and Dr. Rahul will add more to this, because the time to, when you are in the OPD, there are two deliverables. One deliverable is the experience which doctor gives to the patient during that 6 minute, 10 minute, 50 minute, discussion. And one is a prescription, which is a hard copy. So these are the two deliverables of a typical OPD consult. Now, what's happening is that we don't want our doctors to, focus on keyboard. Rather, they should focus on the conversation. What it means is that, when we are talking to the patient, they are listening to the patient, and doctor was able to bring a lot of confidence, and patient gain in heavy trust as far as the doctor is concerned if the conversation is happening and doctor is listening to the conversation. So in this particular case, as soon as the conversation is over, prescription is ready. So what's happening is that doctor is not devoting even a 1 extra minute on the prescription. He may have to do minor adjustments in the prescription, but this prescription is as per the doctor's decided template, which is 100% variable. Second thing is that patient experience is improving a lot, because this particular instructions which are coming in the prescription can be, in our case, in 9 languages, which means that you don't have to worry about what language patient prefers. There are 9 languages. You click, and by click of a button, the prescription is that language. And as a matter of fact, while you're speaking, if there is a Telugu patient versus a Gujarati patient versus a Odia patient versus a Bengali patient, conversation can track that language. The third part is that, when we talk about patient experience, sometimes we realize that, not my handwriting is worse than the doctor's. So I know what it, means. The prescription is not very easily readable. So in this particular case, it's a very comprehensive prescription, capital letter medication names, all medication instructions, very clearly articulated. So this is what it is and how it is important for the doctor. First of all, doctor in this particular case has all the information about this patient in his all health record of the patient at one single place. Second is that doctor doesn't have to, whatever doctor use in terms of frequently used medicines, frequently used diagnosis, instructions, which are like general instructions, have a 45 minutes brisk walk, have plenty of water, stuff like that. They are at one click and you just have to say it is there in the prescription. And what we have realized is that doctor feel very, very comfortable in this tool. And now it is part of the, embedded AI tool for the doctor in the OPD chamber as far as Medanta is concerned.
Okay, so Mr. Sikka says doctors are comfortable. Let me bring in Dr. Bhargava. Yeah. Are you comfortable, Dr. Bhargava? Let's hear.
Yeah. So I think, Pratibha, first of all, we have to understand the autopilot does not mean that the pilot has left the cockpit. It is just trying to make the whole flight much more safer, much more different experiences, and increasing the efficiency of our healthcare system. We are a 1.4 billion people. Okay. We have to understand. And by the time we speak, probably we'll become 1.45. Okay. So there is a bridge, a huge bridge, and a huge gap which needs to be actually filled up between the tier 1 city and tier 2 cities and tier 3 cities. For generative AI, how you tame it, how Pratibha is an intelligent person, she tames it well, and the chat GPT is tamed. Agentic AI is a proactive version of it. So I give a command and I tell them these are my sets of things which I need to do. They will plan it accordingly. When I see agentic AI being utilized in the healthcare system, I see a lot of potentials into that. From a case-based scenarios, right from a pre-consultation technique. What Rajiv ji has said is within the chamber, I've got a bigger problem that people from 50 countries tends to call up and send their problems. Now we have an AI agentic system where we send them the link. They speak in whatever native language they speak. The summary comes to me. It prompts me that this is what is the next generation, what is required. This is the latest data which has been published, and you can give it back to them. It does not mean that without my command, it will go back to the patient. So patient confidentiality is maintained, one. Second, it has not become such a science fiction machine like robots have become robots and they have overtaken the humans. That's a I would say a fear within our minds that one day they will take. But till we are alive, I'm at 47, and I think I'm going to be alive till 90 because of the longevity. Till that thing, it's not going to happen. So we are comfortable. We are also developed our own post-transplant application. So post-transplant app, which we have developed, which is a native app, which we have developed. It means in a journey of bone marrow transplant up to 6 months, each and every parameters is being taken care of. It prompts the patient. So if you have got a loose motion on day 100, it will tell them that you have a loose motions. Please contact your doctor. So nowhere the patient is ever away from the doctor. What has been our problem is about how we follow up the patients. So Pratibha, I think every single aspect of it, how you scale up the mind and the energy of a doctor so as to bridge the gap between us and the district hospital, I think I'm of the opinion that agentic AI has got a huge scope. Under the ambit of ethics, yes, the cyber attacks, the framework, which is not, I'm not the specialist, Rajiv ji and other my co-panelists are the specialists, but I see a lot of potential being utilized not only from service delivery, but also standardization of the healthcare practices. Because once they start having agentic use of agentic AI, It is only giving you what is published. The hallucination rates has started coming down. Whatever is published in the guidelines, so whatever I'm doing here, it will be true in Ludhiana, it will be true in Assam, it will be true in Bareilly as well. So a uniformity of healthcare can be established through the use of agentic AI agents. So I think overall, if we see, AI has got a huge scope provided we can take care of the ethical issues, the data safety issues, so and so forth. It's a huge game changer for Indian population where we are still not been able to take our doctors to the periphery, and they will never go. They will never going to happen that a senior doctor is going to sit and tier 3 and tier 4 cities and going to give the population the same amount of healthcare which is being available at Fortis, Medanta, Max, and so forth. So we have to start thinking about these agents as a tools of ours, which has been able to replicate our mind so that the healthcare delivery is unified. There is a scalability into the system. Follow-ups are better. Pharmacogenomics, and not only this, the other agents like genomics can be integrated into the system so that in overall, we have the ability to live up to 90 years.
Okay. Right now, till the two speakers have spoken, all is fair and looks nice, rosy. But let me bring in Dr. Sujay. I'll bring in Dr. Meher for the public health perspective last. Dr. Sujay, your pointers, please.
No, but I completely agree with Mr. Rajiv, Dr. Rahul, for the enthusiasm that we have across the board with, with agentic AI and the way we look at agentic AI, and we have been using agents for various tasks. At Apollo, we have currently now more than 50 different projects and tasks where we are testing these solutions out or even implementing, out of which about 21 of them are either certified or going through the certified as a medical device perspective, because you would have to understand it from a perspective of the risk that they bring into the system. And risk classifications of this device and others are very important in that perspective. Technologies like ambient listening and then, looking at ambient documentation and all of these. And there are a number of papers now getting published. A couple of weeks back, there was a paper in JAMA. And then, of course, back in April, the NHS came out with a guideline document as to how you go about and managing scribing and particularly looking at
Dr. Sujay, if I can interrupt here, there are a few feedback about your very soft voice. Can you be a little louder?
Oh, okay. Okay, so can you hear me all right at the moment?
Now it's better. Yeah, thank you.
Okay, so I'll just drag my laptop a bit closer. So in all of these, what we are seeing in that changing perspective is this, that while we see the technology evolving, but it's fundamental to have 2-3 things very right in the organization when we are going about in designing, developing, and deploying these solutions. Number one, you would have to see the quality of your data on which these agents are built. And I'll tell you primarily from the process of how this goes about. So you have your raw data where you go about in putting it in a format which is structured. Then you go about in doing your anonymization and other strategies around the natural language processing. Then you move into your generative AI and have your solutions where you move through the processes of, say, indexing, routing, optimization, retrievals, and finally generations. And then on the generative layer, you would have multiple agents that you work on. And on that multiple agents, you would have the orchestration layers, whether you are doing this for a clinical purpose or whether you are doing this for an operational and clinical purpose together and getting there. Now, in all of these, the fundamental thing is this, that how good your data is. And secondly is your process of your natural language processing, your natural language generation, and others, how you have gone about in building that. The third part of it comes out in the way that you would look at it from a clinical accuracy perspective. if you are using this, say, for a clinical tool in, say, transplants, or you are using this from a scribing perspective and others, you would have to look at it in that way. If you're moving ahead and using your agents to use reasoning in the perspective of that, then you need to bring in certain, causal frameworks that comes into the perspective. And then, of course, then you would also have to look at it from concordance messaging, counterfactuals, safety, and others. When you have ticked all of these boxes, then you know that your agents are reliably being used at the clinical end, and you're classified at the risk, and then about it moving. So it's kind of a stepwise ladder to reach to a situation where you would have a safe solution to be given to the patients to use.
Thanks, Dr. Kar. Let me bring in Dr. Meher here. Dr. Meher, you've listened to other speakers also, but the patient volume is really big, which you handle in AIIMS Delhi. So your pointers on this, please.
You must be knowing about the news in AIIMS is a Center for the Central Excellency AI in Healthcare. It is already been awarded by the Government of India. AIIMS is not only the few years they are using AI, they are using for past many years. In the postgraduate graduation students, we are teaching AI. And last 20 years, I'm teaching AI to the postgraduate students. So we have a strong understanding of AI in healthcare in AIIMS New Delhi. Now we come to the AI. We have done some pilot projects since 2010. We have developed one applications, the early prediction of the infection to newborn baby, neonatal ward. And successfully, it is a PhD thesis for one IIT student also. And it is successfully implemented all these things. Recently, we have launched one is early detection of breast cancer and ovarian cancer, ioncology.ai platform. And it is a huge appreciation in across the whole domain. You have covered also the news of that, ioncology.ai. We have used a huge amount of data. It has taken 3 years to clean the data. And there is around 40 doctors, different specialty, they have involved to clean the data. Because any AI model, they need a quality of data. If the quality of data is good or based on the quality of data, your model will give a good result to you. Model is not an issue. Anywhere model is not an issue, is the what type of data you are giving it. And in medical, in healthcare, the data is coming different sources. First is majority of the data is not standardized. And when you use this data, the model may not behave that way. On the other part, I can tell you, anybody they are using any AI model, it is just like a black box for them. Anybody knows what model is used there? In which data the model has been tested? It is not there. Across the globe, there is no single agency is there. We can test the model. Somebody has developed a model, launching in the market. Is there any agency who will review it, give the rating that this model is accurate? And this is the predictions. Because any model is not 100%, they can give the result. But as per the research, if it is giving 65%, then you can start using it. This is the thing. This is the concern about the whole industry. People jumping to in healthcare is a particular very critical domain. That if you use anything, that has to be tested properly. What is the framework for testing this model? Any hospital or any organization using any AI model, is it tested properly? Or you will put a few data, it is not that. It is garbage in and garbage out.
Yeah.
Okay, this model is a very good model. There is no doubt on that. It has tested in a very good quality of data. If your data is not good quality, you're not performing, and the performance will degrade. You have to understand, performance will degrade. So we're supposed to have a one framework that what is the model who are using, what is the risk assessment. We're supposed to do a risk assessment. In ioncology.ai, we have done 3 process of risk assessment to using this model.
Okay.
Okay. So what is the high risk and what is the category of risk? It is in the model. If you go for a third-party model, you will not find that things. Nobody will tell you, this is the risk in this model. This is the bottlenecks in this model. Nobody will tell you. If model is giving some issues, to whom you have to reporting? Is there any process of reporting to rectify it? A lot of things are there because today's days I'll tell AI definitely model. I do not have any objection in it, but the way of implementations, because you do not have any regulatory, the way of implementation is not that way that's supposed to be.
Okay, so important questions raised by Dr. Meher, which we'll have to discuss further. And I would ask all the speakers to be a little short also because we have a lot of questions and limited time. First question itself is gone for 20 minutes. I'm handing over to Vikas sir. Over to you.
Yeah, thank you so much, Pratibha, and thank you all our panel experts for their views. One thing that I must also add to what Pratibha did is that we had the highest, probably the highest number of registrations for this webinar. So the curiosity to really know about what exactly agentic AI is going to do to healthcare is very high. And also a big thanks to our attendees who are very curious to know exactly where we are heading. Just a segue into the next level is what actually Dr. Meher also did. Initial thoughts from you, Dr. Bhargava. When you speak about the use of agentic AI and the convenience that it does between a conversation between a doctor and the patient, and it automatically transfers to your prescription, it definitely eases a lot of hardships, or the cumbersome processes are definitely out. But when you really look at the future, we spoke about just before the conversation started about the requirement of genomic profiling, the advent of targeted therapies. Do you think in those situations it will really aid you in understanding the prescription patterns better? Do you think it is going to be easier for you to really handle patients better? Where exactly are we heading in this?
Because you're absolutely right. I would say there's nothing to fear. One, agentic AI is an augmentative to the doctor's ability to deliver healthcare. Second, fortunately, we tend to read the maximum number of books in the world and still produce the least number of papers. Why this irony? Because we have actually occupied our mind with things which does not matter. So what I'm seeing more is agentic AI tools are helping me to free up my mind space to do the research in these resource crunch country. Second most important point. Third is your own data, which will bring the predictability. There is one aspect of research. So I'm sitting in Fortis, I see 50 patients every day. If all these conversations are being recorded, I do not need to remember 8 drugs having interaction with 8 drugs. Why should I be remembering? Because you tell me 8 into 8, if you do 8 factorial, there can be thousands of permutation combinations. When on the larger databases, when your agentic AI can actually modulate that and give you that, look, doc, you cannot give azithromycin with cetirizine. I'm cautioned about it. So one is the predictability model, which we are talking about. That's a larger companies can develop on a larger data sets of 10,000, 20,000, 50,000, and then accuracy matters can be done. But what I'm looking at is how I can deliver the clinical outcomes to the patient, and that is through these mechanisms. So I think agentic AI is an important tool in the hands of the doctors, which will help them to free up their mind space, do more productive work, and deliver better healthcare to the patient, because it's bi-directional. Patient is even able to understand. There's an AI caller where patient can interact with them. So overall experience about the healthcare is going to change, and everything is not going to be. The prediction is, as Rajiv ji said, everything will be voice. Gone are the days of these desktops and the laptops. It is all your voice. You voice to text is going to be the future, and this is what we are seeing, a generation shift. You do whatever you want to do. You speak, and get it into the text with the accuracy, and you bring in more understanding into the healthcare and with an evidence base. Because now the newer models which has just come up, they actually gives you the references of what they're talking about. So I think each year it is becoming much more smarter, and we are sitting at the cusp of a revolution. Only thing is, we are using the closed loop models. We are not using anything from the chat GPT, so that our data is not going to chat GPT. That's the only thing which I've understood while developing these models at Fortis is you have to use your own closed loop. You have to have your own algorithms so that the data is not being shared with anybody.
Oh, yes, exactly. So again, you ended exactly where I was going to ask Mr. Sikka about the use of data. So are we anywhere close to having a uniformity of data that is being generated? There are like petabytes that are coming. As Dr. Meher also mentioned, the quality of data is something that will hold key. And I don't know if we have reached anywhere close to having a kind of a stack which gives us uniformity, or there is a interchangeability of data from one hospital to another. How do you see that as a barrier? I mean, this is a huge opportunity waiting, and I think doctors like Dr. Bhargava will be really thankful if the load of patients is actually cut, not because of the willingness or the time that is available, but because of the data that is being handled. And there have been so much of reports that have said that most of the doctors and staff in the hospital actually spend time kind of decoding prescriptions and handling registration forms and things like that.
So, I think Dr. Rahul, made all the statements which ideally should have been coming from an AI engineer. Sir, you should take shift from clinical practice to the AI developer. Music to ears. So coming back to your fundamental question, Vikasji, I think you are very right. The fundamental problem of most of the tech, I'm talking right from the ERP era to Windows to now the AI era, has been mainly till date change management, which includes training and other stuff, governance, and also the skill part. But what's the additional in AI is these three are definitely there. These are part of any change management, tool training, and third, governance. But in this particular case, the fundamental to AI is the availability of uniform standardized information. So you said it. Incidentally, and I'm not trying to give any flair to any political agenda. See, we are on 77, 78th year of independence. In those many 78 years, we have been talking about accessibility and affordability of health to each and every citizen. This was the dream even of Mahatma Gandhi ji. So before independence, we have not been able to fulfill this in the healthcare sector. Education is no different. Now, what's happening is that after ABDM or NDHM, which current Prime Minister Mr. Modi ji, announced, I think there is some hope. Now, what's happening is that we already have all of those stuff available in the standard form. There is a SOMAT, there is an ICD-10. I'm just throwing some, technical words. There is a DICOM images. There are interoperability, which you mentioned. There are standards for that. There are HL7 standards. there are fire is called fire, but it says FHIR. These are standards which are already there. So a lot of applications are in that direction. And what Ayushman Bharat has done through Abha ID is one such step in that direction. And in my view, if each and every participating hospital is going through that box, so it will ensure that information is available in the standard form, which means that interpretation of that information will be read in that same form. So that will ensure that what disease Dr. Rahul say it Fortis will have an ICD code which will be interpreted not just in India but worldwide by the same interpretation. So for me, that's the foundation. Yes, you can't suddenly change 77 years of history in one single day, but we as a country are moving in that direction. First time I have seen that healthcare policies have digital intervention. Just imagine that, till 77 years, we were talking of that scale, which we were not able to meet till date, simply because it's not possible. The kind of gap which we had between the demand and supply, it is only possible through tech. And the first time this tech has all these elements, including information exchange in a standardized manner. And for me, on a personal fashion, not as a hospital administrator, but as a patient, as an attendant, this particular piece will ensure doctor portability and hospital portability. Remember that 5 years, 7 years back, we were captive of a Airtel or Jio. Now we can change number from any service provider to any service provider. Same theory. Today I'm a patient of Medanta. I don't like Medanta. I'll go to Fortis. Tomorrow I don't like Fortis. I'll go to Apollo. Simple reason is that my information, my health record are lying at one single place, which is 100% understandable with each and every partner. So I think tool and technology do exist. It's just a change behavior which will come eventually as we move forward, and AI is going to force it by multiply. It's a force multiplier with respect to adoption. That's my viewpoint.
Sure. Yeah. So the key input here is the availability of data, not just within India but also across the world by a common code. I think that's a very big revolution in the offing, and hopefully with the due security guardrails in place. I think we have a long list of questions also, and Pratibha also has her own list of questions. So back to you, Pratibha.
Thanks, Rod sir. I have a few specific questions for the speakers here. So I would like to go to Dr. Sujoy here. As in CMIO, how do you see agentic AI personalizing patient journeys while still keeping safety and transparency at the forefront? If you can give your pointers on that, Dr. Sujoy.
I think it plays a very important role in terms of the conversational element in terms between a patient's query and of course the kind of the information that you would like to pass on to these patients. We have been working with plenty of what we call as a trusted research environment and federated learning, confidential computing, and like that. To build such solutions which has wider worldwide implications and to actually put it into this context. A couple of things that comes to my mind from a safety perspective, and I don't know whether we talk about much around the adversarial prompts, which are like where there could be injections of certain adversarial elements, which would lead to patient safety, say that you can actually inject differences in numbers. So if you are prescribing in a discharge summary somewhere about 500 milligram paracetamol, there could be certain prompts which could actually go and lead these to 10 times of that dose, and then patient goes about and looking at it and comes with an adverse event. How do you prevent those? Because these are now becoming challenges worldwide in terms of the adversarial prompts that are coming into your system. Then, of course, you have to look at it from a perspective of deceptions index. You have to look at it from the hallucination rates that, work on each one of these areas, so that though we have seen hallucination rates go down by almost 6 times in terms of the newer agents that you are coming in that way, but they are not zero. So the way that we have been thinking through this is at Apollo, and we've been doing this for almost 3.5 years now, whether it is through Apollo 24/7 our app, or through our own other systems that we have been able to develop, Ask Apollo and others. The primary thing is that bringing a human in the loop, particularly if the context has a higher risk classification. That's a very important perspective. While certain things like scheduling, the summarization and others can be fully made from an automation perspective, wherever you are having a clinical terms, or wherever you are explaining something clinical, it is important that you bring in to actually complete the sequence and from a perspective of patient safety. Yeah. And lastly, just to add an point in this way, is that while we will have plethora of these, agentic AI come into healthcare, it's about also to then go about in regulating them appropriately, as Dr. Meher was talking about, in terms of appropriate risk classification and the adverse impact that they bring in. It is about also time to actually see how many of them would actually classify as software as medical device and has to go through those regulatory processes.
Okay. So going to Dr. Meher, Dr. Meher, agentic AI can make autonomous decisions is what we all know. Should there be a legal accountability frameworks? Because you also stressed upon that. If AI makes a wrong medical recommendation, who is responsible? The doctor, hospital, or the AI vendor here?
First of all, you have to understand that we do not have any AI regulatory in India. Really very unfortunate that we're supposed to have that. Recently, many small countries, they have come up with the AI regulatory. But one of the best AI regulatory, what I have read it, that is European Union. And they are very fast in this regulatory form. Every quarterly, you will find new amendment in their regulatory. And specifically, they are coming with the European Union healthcare AI models, regulatory models they have come up. But we do not have. What is the status in the government? Government is already in the process to come up with a AI regulatory model plus AI maturity model also. Both the things is coming up by the government of India. Come to the fundamentals. When you are treating a patient, the patient record is who is the owner? Owner is patient itself. We are the custodian. And we have to follow the treatment protocol to treat the patient. Whether you are treating through AI, whether treating through your own experiences, knowledge, and expertise, that is up to you. So anything has gone wrong, hospital is responsible, individual the physicians, not that AI models. Because that's why I want to give a point on this, that we supposed to have any AI model you are using it is not being evaluated by any independent agency. Means you are taking a black box of your own choice. I'm very seriously speaking. We supposed to have a clearly verified that what is the benchmark of the performance of your model, what you are using it. That is also we do not follow it. We do not follow any guideline because we do not have any guidelines that is given to us by any agency. Okay. Just what we do it, any model it is coming to the market, they do the POC. How much data you do for POC? 100, 200, 300? But as per scientific, we're supposed to have 4,000 to 5,000 sample has to be tested on that model. It's not there. So that's why, and regular, because it's supposed to be a framework, regularly you check the model, how it's performing. So that assessment supposed to be done. So that is also not there. So if you talk about the responsibility, anything has gone wrong, in that cases, itself the policy of the own organizations, they have to take care of that.
Okay. Yeah, I could say, Dr. Bhargava, you have a point to make. Yeah.
So, Dr. Sushil, the important thing which we are talking right now is how it is augmenting your ability to reach to the right diagnosis, right patient care, and help you in the research. We are not making and deploying as an autopilot mode to deliver, to listen, and deliver the healthcare. So that is why it is very important when we are developing our own models. We should not blindly take the models from outside, because what is my requirement in hematology will not be a requirement for a gastroenterologist. And gastroenterologist's requirement will be entirely different from cardiologist. So I think one size fits for all does not hold true. I have got 180 interventions in a hematology patients on a day-to-day basis. So that amount of data, what AI is, agentic AI or generative AI is giving me an ability to actually churn it out and bring out the meaningful predictive model, which I continue to bring finesse into it, so that ultimately it becomes the model which helps my life to become smoother. So just a small example I'll give you. So my patient gets chemotherapy, 5 types of chemotherapy, and we used to get everyday CBC done for each and every patient. Look at the cost of the amount of money which as a patient has to spend. Now we got the dump of 120, 150 patients on 5 different chemotherapies, and we made a model that by day 2, no counts will ever fall. Whatever you bring, 5 of us gets, whatever ethnicity, whatever religion, whatever state you are coming, before day 2, it will not fall. So it means 6 days of CBC, complete blood count can be prevented, which was unnecessary done. So we have to actually define the problem first, then bring the right data, and with the right data, have to answer and get the right question in our mind to get the right answer. Till the time all these things are not there, we will be actually in like a universe, seeing stars and going nowhere. So this is how I see agentic AI, as an augmentative ability to help the doctors to actually bridge the gap. So say thalassemia, you have government has put HPLC machine across the country, but it is being run by technicians. The doctors are not there. So what we did with Madhya Pradesh, we start getting CBC and HPLC reports on us on the WhatsApp. So one doctor is continuously putting it HPLC report, thalassemia trait. Then what thalassemia trait? So now this AI agents has given, this is thalassemia trait. In their native language, it tells, भैया शादी के बाद बच्चा पैदा करने से पहले थैलेसीमिया की जांच करना, हस्बैंड की भी ये जांच कराना. And this goes as a voice recording to the patient. Because by 2035, we feel that thalassemia should end. So I think there are various models. Each model has got its own robustness into the ambit and the ethics, and data leakage has to be the priority. We cannot put the data on ChatGPT so that it gets to the world. That's the only thing.
Yeah, Dr. Sujoy, your points. Very briefly, Dr. Sujoy, we have questions here.
So going to the example of what Dr. Rahul said, if you then look at certain, prediction model where you are not going to test on the second day of chemotherapy, what we are saying essentially in the perspective of risk is that ascertain the risk of why those tests would not be done. And when you are collecting the data from your own patient and looking at it, have it developed at your center, test it at other centers, get it peer reviewed, and then you go about in using this in prospective use. So what you have is a systemic backend by looking at the insights of your data to make general change in the recommendations that are coming in. And that's the path that we would have to follow for everything we do.
Okay. So let me go quickly to Mr. Sikka here. I wanted to ask this question, sir. With multiple vendors and cloud platforms and EHR systems in play. Where do you see the biggest vulnerability for data breaches? And what should the CIOs prioritize first, the firewalls or the encryption or the governance?
So it's a mix of all. You can't say that I'll make sure that my door is closed, but I'll have my windows open, or I have my windows and doors closed, but my boundary wall is open. You have to look into the holistic perspective of each and everything. But in my opinion, the same story was there with Aadhaar when we launched Aadhaar, that what will happen to such a huge information. I think and it's not that only healthcare is doing it for the first time. Complete banking industry, complete insurance industry, FMCG, consumable industry are all on the cloud, or in the systems which are on the internet. So there are few fundamental principles which remains unchanged. First of all, your data has to be, I'm just oversimplifying it so that people at large can understand. Your data should be in an encrypted form. Any access to the information has to be through authenticated mechanism. Third is that any access which is done is having an audit trail. Fourth is that you have this information in a distributed fashion, which has two advantages. One, in case of a breach, you can rely on the other. Second is that it increases performance. So there are plenty of tools which are already proven. Definitely, cybersecurity is an evolving subject. Viruses keep getting added. Cybersecurity tools which are catering to all of these keep evolving. So it's not an end, but ultimately, if we keep thinking about only and only cybersecurity, we'll not reach anywhere.
Thanks a lot for that explanation. Was very important. Vikas sir, over
And
to you.
Pratibha, I think the
Yeah.
fear cannot guide us always. I think you have to move ahead, keeping everything into consideration, but fear cannot stop us in adopting the AI.
And just to add to what Dr. Rahul said, very rightly said, see what's happening is that AI has solved many problems than it has introduced. And all the narrative which is happening is, focusing on the possible issues which could arise because of AI. So many problems have been solved, which are like almost in multi-thousand. And even if one or two issues are there, I'm not denying that those issues have to be resolved, because healthcare is all about life and death. But let's focus on what has resolved. We are just talking about only one narrative, fear. What will happen?
Okay, I'm talking to all the health tech crusaders here. I'm handing over to Vikasa. Vikasa, we had few other
Yeah,
questions which are patient centric. Maybe if we can talk about that.
sure. No, and thanks so much. Our speakers are also taking some of the online questions, so it really is a good booster for the audiences also. Dr. Bhargava, you mentioned about 1.4 billion population, and most of the modern changes that we see are actually at the top metro hospitals, because the affinity is higher, the investments are better. Do you think there is a case for democratizing AI, agentic AI, and how it can actually permeate down into the smaller cities? I think
Vikas
that
ji,
will hold the key.
yeah, इसका जवाब मैं हिंदी में देता हूँ सर. That's
Ah,
the first democratization.
of
So
course.
we have to understand, sir, कि गूगल में जब आदमी पढ़ता था तो वो विचारधारा, अमेरिकन विचारधारा से उसके जवाब को पढ़ता था, जिससे उसमें भय पैदा होता था, डर पैदा होता था, और वो कंफ्यूज हो जाता था. अब एआई के जमाने में हमारे को अपनी लीड लेते हुए अपने सिस्टम्स को इस तरह से डेवलप करना है कि मेरा गोरखपुर वाला बंदा भी, अमरोहा वाला बंदा भी, बरेली वाला बंदा भी चैट जीपीटी या एजेंटिक एआई को यूज करके करेक्ट चीज पे पहुंच पाए. बिकॉज व्हाट आई एम सीइंग chat gpt or generative ai or agentic ai as a tool of bridging the knowledge gap between the various hospitals and the doctors, because what is happening in the background is all the data, all the data which is there. Now agentic ai, the hallucination rates have started coming down. It will only give you what I should do in aml. In acute myeloid leukemia, this should be the strategy. So tomorrow, this is in the power, in the hands of the people actually now, without going to the jargons of OS or PFS, which they never understood. They understood मैं बचूंगा कितने दिन, मरूंगा कितने दिन में. अभी एजेंटिक एआई यू आस्क इन हिंदी, ही विल टेल यू आपका एएमएल है, आपके बचने के चांसेस अच्छे हैं, आप 5 साल पे आपका चांस है इस म्यूटेशन के साथ, आप 60% टाइम जिंदा रहोगे. दैट मेक्स माई लाइफ इजी, दैट टेक्स आउट द फियर फ्रॉम द माइंड्स ऑफ द पीपल, and it helps to deliver the healthcare at the last mile. So that is the too good of a democratization of the healthcare, because now every person is accessible to the real knowledge in their own language and in their own world and in their ideologies. So I think it's a huge task for all of us, whoever is generating the AI models. We need to have our own AI generative models, how our psyche works, how what questions which we ask to the doctors is what is going to give us the answers and actually improve the patient care into tier 2 and tier 3 cities. So that is our problem which we need to fix. गुड़गांव मुंबई में तो बहुत डॉक्टर, बहुत अस्पताल, बहुत सब चीजें हो गई सर. अब जमाना अगर देश को विकसित बनाना है 2047 तक, तो टायर 2 टायर 3 सिटी में जाके काम करना है.
And just to add to what Dr. Rahul said, see, AI and most of the tools are not for hospitals like which Dr. Rahul mentioned. Just imagine that a general practitioner who's, at the in the remotest corner of the country, sitting on one foot, treating everything from head to toe, वो ऑप्थेल का डायबिटिक रेटिना भी देखता है, वो आपके पेट का हाथ लगा के बिना अल्ट्रासाउंड के बीमारी भी चेक करता है. So we need those tools for those kind of people, not for Dr. Rahul to figure it out कि वो BMT होना है कि नहीं होना.
Absolutely right, sir. सर एक छोटा सा बस 2 सेकेंड. सर सीबीसी में 2 पैरामीटर आते हैं, एमसीवी एमसीएच. उसको देख के हमने थैलेसीमिया 5 सेकेंड में बना दिया. तो उसने गूगल पे रिव्यू लिखा कि डॉक्टर ने 1000 रुपए दे के 5 सेकेंड में डायग्नोसिस बना दिया. उसके लिए बेचारा वो बरेली से 300 किलोमीटर चल के आया था, क्योंकि उसका हीमोग्लोबिन 10 था और एमसीवी एमसीएच लो था, जो थैलेसीमिया ट्रेट था. तो आज की तारीख में एजेंटिक एआई के माध्यम से मैं फोटो डालता हूं, वो बोलते थे थैलेसीमिया ट्रेट है, 300 किलोमीटर का डीजल और पेट्रोल उसका बच जाता है और 5 घंटे की वेट बच जाती है. दिस इज हाउ आई सी this agentic AI is helping people to get command into their own hands and not only rely on the healthcare itself. So I think it's a beautiful world. We need to have our own systems in place under the ambit of ethics and data privacy, but we should latch on this moment of glory of developing our own AI tools which ask us the right questions.
Because if I can interrupt, I think Dr. Sujoy, you had a point. If you can quickly make it, then I'll ask the question. You had a point to this?
Absolutely, no doubt. And that, of course, we're not talking here about apprehensions or fears. But I think one of the most important thing is for any tools that we see in healthcare, we will have to weigh it with the risk and benefits. And of course, the benefits are large, but in making it, one thing about is consumer grade, the other is about clinical grade. And when you are handing tools in hands of people in the periphery, even if, the doctors are the last mile, you need to ensure that what are the guardrails that has to come in with it. And therefore, to go through the cycle of how you do these risk assessments, how do you make it as a software, as a medical device, is something that has to happen at the maturity curve of this country.
Okay. So with that, I also have this question. Sorry, sir, I had to interrupt, because even many doctors struggle with basic digital tools like electronic health records. Dr. Bhargava, you are one you have all the technical knowledge, but not many of our doctors, especially from tier 2, tier 3 cities or from the rural side, if they can't audit or question AI decision, who takes the responsibility when something goes wrong? Is there a danger that AI becomes a crutch where over-reliance makes doctors less sharp and patients more passive? Anyone can take this question.
I think that's a fear. But Pratibha ji, if taken into the right context and understanding and knowing, it is going to actually bring in more, it will bring in more value to the people, because there's a lot of knowledge heterogeneity at this present moment of time. I think the current models which are being utilized are, and the problems which we are trying to solve at the periphery are not rocket science. And that is why these models are less likely to fail. The fear is what we are talking about. We are talking about a radionomics where there's a lesion, whether to biopsy or not biopsy based on the AI, that is wrong. My problem is of CBC report, whether it's a vitamin B12 deficiency or whether it's an iron deficiency. So I'm talking about a very, very basic problems, which is very difficult to comprehend, that what happens in Gorakhpur, Sivan and rural healthcare in Chhattisgarh. So I think if tamed nicely and answered those questions, which are our own problems at the rural hinterlands, actually this can be a great model to serve. There will be problems. I will say there's never a thing which is not without a problem. There will be problems, but still it's a huge tool to bridge that gap. And the knowledge gaps, as we understand, I'm sorry to suggest the amount of doctors which are being produced in this country, there will be a huge knowledge gap in the coming days, as we are going to see in the next decade time. So agentic AI has to be tamed in such a manner that it augments the ability of a doctor to give the right clinical condition and determination and outcome to the patient.
So
Pratibha, it is like, it's like a stethoscope,
I don't want to
which
debate with
Dr.
Dr.
Rahul
Rahul,
Bhargav.
but I think it's a very interesting.
I think both of them had a point. Dr. Sujoy, yeah, please go on.
Yeah, so I don't want to debate with Dr. Rahul on this, but I think he makes a brilliant point in about the outreach of this. What I'm trying to do is I'm going to, from a practical experience, and then of course how the things are moving. Clinical decision support that you have been naturally bringing in at the output of an AI, whether it is a deterministic AI or a generative AI perspective, needs to now shift to what we are calling as the intelligent choice architecture. Because sometimes at the time, if you bring only the element of do this, do that after you have got an AI output, that can be creating what we call as the dependency on our clinical workforce.
Okay.
And we may be losing on what he makes as a point of the different choices that you would have to do about that particular tumor that you would have, whether you are going to go and do a biopsy or not. Those intelligent choice architectures are required at certain levels of your devices and risk classification, whereas certain levels you can go about and play around with your clinical decision support and move ahead. So what we're going to see in future is a mix and match coming through from how you are going.
Mr. Sikka, I think we lost. Yeah.
No, I was just saying, that AI, as rightly said by Dr. Rahul, is like a stethoscope. And he's having it on his shoulder. Right now, it is useless. And once it comes in the hand of the right person, it will do wonders. It is not to figure it out what your biopsy report is saying versus what your PET CT is saying. That kind of a difficult decision has to be made by people like Dr. Bhargava. But in simple cases, where you have to figure it out, ki diabetic retina hai ki nahi hai, there is an AI tool which will help you. So that guy doesn't have to move 300 kilometers, spending one full day. Maybe he's a daily wages worker, losing his daily wage, and to get a 1 5-second prescription from Dr. Bhargava ki haan bhaiya DR hai tujhe. So that's what is AI. It is about simple, basic, primary and secondary diagnosis, which can easily be done. It's like a stethoscope. You hear the chest, you figure it out.
Dr. Rajiv, the amount of the data which you have said and the platform which you have created. So let's put it into a OPD of Civil Hospital of Gurgaon, where my wife sees 100 patients in a day without asking 10 different questions. If somebody can ask those questions and that is printed out, that data is kept, and the doctor has to spend less time. So in a government healthcare, if somebody can take a history, or he can put those history into the text by just saying what he's doing. In an AIMS OPD, Pratibha on a Friday, you have got 300 aplastic anemia from various quarters, 306 doctors. How can ever you see that? So if you have this app where they're just speaking and their numbers is assigned, their whole history comes to the patient, a doctor's dashboard, they see it and 5 minutes job done. So data is kept, history is kept, and outcomes are made better. And then you can follow up and do the research as well. So I think what is the framework which you are looking at and what problem you're trying to solve is going to help us out. So from an AIMS data, so now they have got 5,000 aplastic anemia. We still do not know where there's a hotspot in Uttar Pradesh and Bihar where the aplastic anemia is coming from. So from a public health point of view, I just have to type those data. Agentic AI will give you an idea which is the hotspot, analyze the whole area with the environmental factors, geopolitical factors, and it will give you, this is the hotspot. Sivan is a hotspot. Let's go after Sivan. So I think we are not looking at the possibilities, and let's not get bogged down by the fear of losing out on the data. We will always bring the framework because we have got great people who are building frameworks for this AI models in India.
Yeah, I think I'll keep on debating if I'm sitting with Dr. Bhargava because that fear factor as a patient I always have. I always depend on the doctor, not on the patient apps. I would go back and give it to Vikas sir. We have already touched 4. If you can just do the closing, sir. So you're on mute.
Yeah. Sorry. No, I mean, I wish we had a lot more time, but in this 1 hour, I think this was one of the most exciting conversations that we have heard. Boundless potential of agentic AI, but provided we make the right use of it, and all points taken are so beautifully summarized. About having the implementation process, the clear benefits that Dr. Bhargava mentioned. I think the clinical outcomes Dr. Sujay Kaur also mentioned. I think net on 2 pillars, the patient centricity stands: cost of treatment and speed of treatment. I think if we can crack that in a country like India, which is like having a humongous problem of managing healthcare and its systems, I think we would have gone a long way. I'm sure, I think we definitely need to revisit this topic again. But thank you so much for all your, beautiful views on a topic. I think we've come out quite well educated, Pratibha and me. Definitely, we'll have a lot more coming. So thank you again, and thank you so much. Also, the audiences, great questions, and of course, all the questions were also taken.
I want to give one point to you.
Sure.
There is one word is subliminal. Subliminal. The spelling is SUBLIMINAL. Okay. It is a such things. Now it is coming as an act in European Union. Okay. It is giving a lot of influence to the data. And if the data is influenced, your models again cannot perform.
Yeah.
So please, all the people do not know, please go through it. It is available in the net, Subliminal. Okay. And second question that is there. Why, when you are using any model, how it will be safe, that has to be looked into it. Model poisoning is coming in large scale. Model poisoning is coming in large scale. Earlier, the data poisoning was there. Now it is model poisoning is coming large scale. So be careful on this. When you are using any model, so that has to be more safe. Otherwise, you will in trouble. Yeah.
Sure. Yeah, words of caution coming from Dr. Meher. All through, I mean, this is exactly what makes a good debate. From both sides, we had points and counterpoints, but I'm sure the outcome is going to be beneficial to the patients, and that's the whole objective for all of us. So thank you so much, sir. Your point is taken on having a proper guidelines, which actually is taken from some good international regulatory systems, as you mentioned, from the European Union. Point well taken. We will definitely keep following back on this. Thank you so much again, and this was one of the most fascinating debates. Thank you.
Thanks a lot. Yeah, as Vikas sir said, we'll come back again maybe in 3 months down the line and again check how the agentic AI is shaping up. So there were we had Dr. Google now we have agentic AI doctors. So there in between we have a lot of CIOs and hospital leaders who are pushing for the tech choices. So it's a lot of things which we have debated and discussed. We will come out with a nice article after this, with the webinar. So thanks a lot for each speakers, and please help us pouring in your expert views, write articles also for ET Health World. Thanks for joining once again. Thank you so much.